Good morning, everybody. Welcome to the PHRN Impact Seminar for the 5th of May. First up, I'd just like to acknowledge the traditional owners of the lands of which I'm on, the Whadjuk people of the Noongar Nation, and pay my respects to elders past, present and emerging, and extend those respects to everyone who is joining us from all over the country. Today we've got a really exciting session. We've got Associate Professor Judy Katzenellenbogen and Dr. Ingrid Stacey talking to us about the ARRAISE study. Judy is an epidemiologist with extensive public health experience in Australia and internationally. Her work focuses on Aboriginal cardiovascular health using linked data to drive better health outcomes. She's currently working with UWA and Murdoch University in Western Australia. Dr. Ingrid Stacey is a cardiovascular epidemiologist and biostatistician. She is a National Heart Foundation postdoctoral fellow at UWA with an affiliation at the Victor Chang Cardiac Research Institute. And Ingrid's work focuses on improving heart health for First Nations people, and particularly around preventing rheumatic heart disease. So today's webinar is focusing on acute rheumatic fever and rheumatic heart disease in Australia, drawing on findings from the ARRAISE study. We know that rheumatic heart disease is preventable, yet it continues to be disproportionately affecting First Nations communities in Australia, particularly in remote and disadvantaged settings. So using national linked data, the ARRAISE study is providing some new insights into the true burden of the disease and outcomes across the population. We will be using the Q&A function, so if anyone has any questions, please use that function, and then we will have time at the end to ask Ingrid and Judy anything that we might want to delve deeper into. So I'm going to hand over now to Judy and Ingrid. Thank you.
Thanks, Beck. So Ingrid's in the room with me, but she's out of sight now, but she will be in sight soon. So I'll just share my slides. There we go. So before I start, I'd also like to acknowledge the Whadjuk Noongar people as the traditional custodians of the land where we're meeting today, and we can see this model of the Perth area pre-colonisation, which is quite stunning. I'd also just like to acknowledge that the statistics that we are presenting here represents the loss of health, human life, with profound sadness for people, families, community and culture, and that these numbers obscure the resilience and strength of the people involved. And of course, we like to tell the story often, not just the stats, but also the lived experience, which we won't be talking about today, but we do see those things as sort of working together in understanding rheumatic heart disease in Australia. So our structure for today is just talking a little bit about the disease, the ARRAISE study design. We'll be talking about some specific studies with 8 exemplars to show how we've used linked data and identified different cohorts to ask different questions. Just briefly touching on some of our translational activities and current and future research initiatives in Australia generally. So rheumatic heart disease is a complex disease with multiple stages, and it all starts with a group A strep infection. Now, this is treatable with antibiotics, but in cases where people are not treated, there's a minority of cases who get an autoimmune reaction called acute rheumatic fever. Acute rheumatic fever manifests with joint pain, sometimes with uncontrolled movements, and skin blotches on your skin, as well as pericarditis, which affects the heart. And it is transient, so one can recover from acute rheumatic fever, but there's a tendency once you've had it once to get it again and again. And if you do have the recurrent episodes, you might get worsening of the heart valves. And when there is permanent damage to the heart valves, it's called rheumatic heart disease. BPG is the antibiotic of choice for treating, for the secondary prevention of rheumatic heart disease, in order to prevent recurrences of acute rheumatic fever. Some cases of rheumatic fever are quite mild, but there is a spectrum, and on the severe spectrum, there are many RHD-associated complications like surgery, atrial fibrillation, heart failure, endocarditis, complicated pregnancies, stroke, and death. So it is associated with significant loss of life and quality of life. Around the world, there are certain areas where it is very, very prevalent, rheumatic heart disease. And we can see sub-Saharan Africa is one such area where it's very prevalent. And North America, Western Europe, and Australia have very low rates. And that's wonderful. That's a reflection of the access to antibiotics, improved public health and environments, and so on. But in Australia, we actually whitewashes a little bit what we see in Australia, because in Australia we have evidence of two concurrent patterns among non-Indigenous people. It reflects the previous epidemic before the 1960s, before antibiotics. At that time, acute rheumatic fever and rheumatic heart disease patients comprised a large proportion of people on the pediatric wards. But now that is mainly a thing of the past among the non-Indigenous population. However, among First Nations people, there's an ongoing epidemic. The mortality rates are 18 times higher among Indigenous compared to non-Indigenous people. And we now have RHD registers with 12,000 people on them, and 81% of those are Indigenous as of 2024. Just a little bit now about why it is so prevalent. This is the pyramid of rheumatic heart disease, as I've described already: acute rheumatic fever, going into rheumatic heart disease, and then the complications. And we obviously have the building blocks of actions, which are really the medical treatment of this. And the 2009 Rheumatic Fever Strategy, funded by the Commonwealth, focused on secondary prevention and getting registers going around various states, not all in Australia. But more important to this top of the pyramid is what's at the bottom of the pyramid. And here we see that colonization, the purple bar there, is really is driving the high rates, with the loosening of the bonds of culture, language, community, country, and healing practices in the Aboriginal and Torres Strait Islander community. So these effects of colonization have resulted in what we call the poor social determinants of health, things like poverty, poor physical environment, housing, and so on, systemic racism, and so on. And so that is then the basis for this cascading of strep A infections and skin and throat infections, coupled with the normalization of the infections and limited health literacy, has meant that the prevalence is very high of rheumatic heart disease and acute rheumatic fever. So really we're seeing this driving the problem that we see today in Australia. So we'll be focusing today our study on the End RHD in Australia study of epidemiology. That's ERASE study. This started in about 2018 with the aim of describing the burden and the management of these diseases in 5 jurisdictions. It was NHMRC funded and was supporting and the End RHD Centre of Research Excellence as providing the baseline burden for that Centre of Research Excellence. Our linked data analysis involved WA, Queensland, South Australia, Northern Territory, and New South Wales. The first phase was around the burden of the disease, and the second phase was around outcomes. And we'll be talking about just briefly about those 2 phases. We also had a health systems component, which we won't talk about today. And we had a very close association with the lived experience research that went as part of this, as Emma Haynes's thesis, which was an outstanding piece of work. So a little bit about our database. The linked data collection has at its core the RHD registers and the hospital records. Our cohorts are mainly developed are derived from those two sources. And we also have the death records of those people. We have some primary care data from the Northern Territory. We have surgery records as well as midwives records from some of those states. And the data collection then comprises people with acute rheumatic fever and rheumatic heart disease in these states, covering 2001 to 2018. And we have the demographic, the acute rheumatic fever episodes, RHD diagnoses at various points in people's lives, pregnancies and births, the date and cause of death, as well as the ability, obviously, as you all know, to undertake longitudinal follow-up of these people. So this is just a quick overview of the availability of various data sources. We see that WA there has the hospital and death records going back further than the other states, so we have longer time frames. The Northern Territory has the most complete registers, starting actually before 2000. For all the other states have their registers, but they don't all start at the same time. So generally, it was a complex data set to try and sort of find how to have a uniform approach across all the jurisdictions. We ended up with a database of people of various ages, and this reflects when they were first diagnosed or when and we can see here on the left is the Indigenous profile, the age, as well as on the left, acute rheumatic fever and rheumatic heart disease in blue on the right, and for non-Indigenous on the other side. The Indigenous population, you can see, is a much younger population. The cases are younger, and acute rheumatic fever is still very, very active among the young people, peaking 10 to 15. For non-Indigenous cases, actually, it's dominated by older, predominantly survivors of the pre-1960s epidemic. So we have a very different profile, and we decided to focus on 55 and below because we are interested in the current epidemic and particularly the effect on Indigenous peoples here in Australia. So all our cohorts tend to be young cohorts, and Ingrid will talk about that as well. But we did have a problem. We needed to identify RHD in hospital records, and usually we do that with codes. And when we looked at the codes, we realized that there was a problem with the RHD codes in that we were not able to always differentiate whether a valve problem was truly rheumatic or non-rheumatic in origin, because there was a default to rheumatic heart disease in certain valves. So we identified the problem in this particular publication, and we developed a solution where we have a prediction model for ascertaining rheumatic heart disease in administrative data using codes. We were able to do that because we had a data set from Queensland where we interrogated we interrogated the audits from all coded ARF and RHD events in Queensland. A person then went through all the folders and identified whether it was true or not based on clinical data. So we then had that as a background to developing this prediction model, which we used throughout. The next thing we needed to also look at was where are we getting, would it be okay just to do hospital data, or do we always need register data or whatever? And so Treasure Agenson here, she was an honours student at the time, and we did a study looking at the overlaps of cases between hospitals and registers, and we found that among Indigenous people, 23% were only on hospital and 40% were only on register, whereas for non-Indigenous people, they were almost not on the register at all. So we absolutely needed to use both data sources to have a level playing field and to ascertain most of the cases. We also have the issue is is the first date the true first date? And we just looked to see if we looked at the first date of diagnosis that we have available on the register of the hospital, if we look back, could we find a case where there was a misdiagnosis? Because we know that the diagnosis of acute rheumatic fever is very difficult. There isn't a test for it, and it's a syndrome really. So John Woods here went back into, we had a look back period where we looked at mimics, RHD and ARF mimics, prior to their first date and tried to see to what extent there was a missed diagnosis. And we found about 8% experienced a mimic prior to their diagnosis. We think it's probably a little bit more, say 10%. So, and this is an issue, and we thought that would highlight the importance of having clinical suspicion of ARF or RHD for clinicians. It's very low, and it can lead to a delayed diagnosis. Probably our most widely published results are from our burden paper. It's Contemporary Incidence and Prevalence in Australia. It was really a landmark paper. We've got now 111 citations and counting. And here we see the age standardized ARF incidence among Indigenous Australians, 2015 to 2017, under 45 years of age. And we can see here Northern Territory has the highest rates, and some of the Kimberley, and there's a north-south gradient that you see there. Very low in New South Wales. For rheumatic heart disease prevalence, we see a similar north-south gradient, but the top end of the Northern Territory being very, very high. WA having a ranking about second with Queensland on the prevalence. The incidence of acute rheumatic fever is slightly higher in WA on the left compared to Queensland. So I'm going to hand over now to Ingrid, who most of what she's talking about now is actually her work that she did as part of her PhD as well as part of her postdoc. So I'll hand over to her now. Thanks.
Well, thank you, Jodie, and hi everyone. Thanks for listening in. So from where Judy has taken us to this point, we're going to now pivot and think a little more about the outcomes of acute rheumatic fever and rheumatic heart disease. And for study 4, one of the first questions that we were asked was, are these rheumatic heart disease registers making a difference? So for this particular study, we actually just honed in on the data that was contained within the RHD registers, which, as Judy mentioned, were funded in 2009 as part of the rheumatic fever strategy. So we really defined the cohorts for this analysis based on those registers. And that was because, as Judy mentioned, they've got that much more granular information that includes things like disease staging, was the RHD mild, moderate or severe, and also some injection date information, which let us measure medication delivery to people with a diagnosis. So this kind of information, as you're probably all aware, is not available on our regular hospitalisation records. So the first question within this analysis was, are the disease progression levels changing at the population level over time since the funding of that rheumatic fever strategy? So for this cohort, we looked at people who had an initial episode of acute rheumatic fever, and we looked just 2 years later to see if they'd had a recurrence over that time period. Each person with an initial ARF diagnosis was assigned to a calendar year-based cohort, and then we looked by calendar year to see if recurrence rates were perhaps decreasing over time. As you can see from this graph on the screen, they were just remaining stable, but these were actually quite low rates. About 10% of people had an ARF recurrence within 2 years of their first diagnosis. So that was lower than the only previous Australian study on this topic. So we were feeling a little like we were seeing some improvements at the population level. The next part of the disease course we looked at was slightly later along the natural history of disease. This time we looked at people who had a mild RHD diagnosis at first, and within 2 years, whether they had progressed to severe rheumatic heart disease or died in the time period. And as you can see here, we've got around 2.5% on average over the 6-year study period. And this is a low and stable rate. And compared to international estimates from the prospective remedy study, this is actually in absolute terms quite low. So unfortunately, we don't have data preceding the 2009 establishment of the registers, but we feel like this data showed stable and low disease progression rates. The second part of this manuscript looked at, are people with ARF getting the treatment that they need in the form of the secondary prophylaxis? And for this, we just calculated the median secondary administration of the penicillin injections in the first year after someone had had an ARF episode. So that was using a percentage days covered measurement. And as you can see, we've got a trend towards increasing coverage by those injections across everybody that we had in the registered data set. But you can see by the dots in the background, there was some heterogeneity within that measurement. So the study 5 was then looking slightly more medium term, looking at the outcomes happening in this longer term, where we were measuring outcomes of uncomplicated RHD in young people. And in this instance, we went back to looking at RHD registers and combining it with hospitalisation records to define our incident cohort. So for this study, we looked at uncomplicated rheumatic heart disease, and you'll notice I've changed my language from talking about mild, moderate and severe to now thinking about uncomplicated, and that's to do with the data sources used here. As we've highlighted, the hospitalisation records don't have any indication of disease severity, so we had to create a proxy, and that proxy was considering admission records that did not have within the episode of care a co-diagnosis of heart failure or a surgical procedure for a valve replacement or repair. And we considered those as uncomplicated. And from the RHD register data source, anyone with a mild or moderate disease severity rating was also put into this uncomplicated category. So in light of that definition, we were able to do this retrospective cohort study where we found almost 1,800 young Australians aged less than 35 years diagnosed during 2010 to 2018. And we followed those people up with all data available to us within arrays. And what we found was that within those 8 years, almost 1/4 experienced our composite outcome, including surgery, heart failure, atrial fibrillation, endocarditis, stroke or death. And sadly, among these young people, around 3% died. 16% needed surgery, which oftentimes meant people were travelling very large distances at a young age away from their family and communities to have those surgeries as they moved from remote areas to tertiary hospitals. And 8% of these young people experience heart failure. So these are really quite severe outcomes for such a young cohort, particularly when we're talking about heart disease. The risk predictors for experiencing those adverse cardiac outcomes was if you had your RHD diagnosis at an age over 15 years, you were more likely to progress quite quickly to your adverse cardiac event. And similarly, if you lived in a metropolitan location, you are more likely to, you're at a higher risk of experiencing these outcomes. And we hypothesized in this study that that was due to a later diagnosis in metropolitan settings. Judy just showed us those misdiagnoses, some evidence of misdiagnosis in our arrays data collection. But also we do know anecdotally that registers and screening programs will focus their efforts on remote and rural areas. So we suspect that's another reason. Also, people in metropolitan areas do have access to surgery a little sooner, which could have led to this observation. We noted that having a prior record of acute rheumatic fever was protective, which we hypothesised was due to this opportunity to intervene and manage the disease from progressing and give people secondary prophylaxis. So within that overarching outcome study, we then decided to really focus in on a special population of interest, and that was women with rheumatic heart disease who became pregnant. This was really important because women actually experience twice the burden of disease that men do. And sorry, they experience twice the risk of rheumatic heart disease compared to men. And the peak onset of rheumatic heart disease, as Judy showed us earlier, is actually in the childbearing ages. So for this study, we again defined an incident cohort based again on register and hospital records. But at this point, we created a novel linkage to the midwives data set that was introduced about halfway through ARRAISE in order for us to undertake this study. So we looked in at women aged 12 to 44 years who had their first RHD diagnosis before they turned 35. They had to have had at least one birth record on the midwives data set to be included. And we decided to use that midwives data source because you get this very clear gestational age at birth measurement, which allows you to estimate a date of conception, and you get a very clear then window of pregnancy exposure for your analysis. We also focused in on RHD that was diagnosed prior to 20 weeks gestation of the infant, because there were several studies, Australian, New Zealand and internationally, that documented cross-sectional analyses of really quite catastrophic associations between diagnosis of RHD that did occur at birth. So we had pregnant women with undiagnosed RHD giving birth, which, as you can imagine, had very poor outcomes for women, but also their babies. We actually decided there was a need for information that was a little more prognostic and of value to women who were living with known RHD to inform their family planning decisions, which is why we settled on this known rheumatic heart disease in the first half of pregnancy. So with this very clear definition in mind, we were able to find 393 women who experienced 646 pregnancies. We looked at, we again used all ARRAISE data to look for outcomes, and we settled on RHD MACE, which stands for Major Adverse Cardiovascular Event, which are our regular cardiovascular outcome composite that we looked at in the previous study, but also some more pregnancy-specific outcomes as well, like pulmonary hypertension, edema, and cardiomyopathy. And what we saw was in the group of women who started out their pregnancies with complicated RHD, almost 40% progressed to one of these RHD MACE events, and around 5% in the uncomplicated RHD group progressed to an RHD MACE outcome. The most common outcomes were the secondary pulmonary hypertension and heart failure, with a small minority in the complicated group requiring surgery as well. We also did pregnancy as a time-varying exposure analysis and estimated that women with known rheumatic heart disease had 3 to 5 times higher risk of cardiac event during a period of pregnancy. And you can see on this Kaplan-Meier that we have here, that very steep number of events up to the 40-week gestation period, and then a plateauing of that risk. And our message is that the risk of RHD MACE is really proportional to the disease severity at the start of your pregnancy, really highlighting the importance of those early cardiac appointments for women who know they have RHD or are at risk of RHD to help them have favourable cardiovascular outcomes during their pregnancy and afterwards. The 7th study was looking at RHD mortality in Australia. This was a really interesting study because we actually did 3 different data sources to look at this. We actually submitted a separate unlinked Australian Bureau of Statistics custom data request for ICD-10 coded RHD cause of death within those national statistics in order to undertake this analysis. You can see here on the screen in the blue box, in the purple squares in the graph on the left there, we've got measurements that were reported by Cahoon and others in JAHA in 2015. And you can see in the green squares our estimates for the 2013 to 2017 period. And the message there is that across all of those broad age groupings, mortality due to rheumatic heart disease has declined. And most substantially, the decline was seen in the 25 to 44-year-old age group. So we are moving in the right direction with a reduction in RHD mortality since last reports were estimated. Worth pointing out, we replicated the analysis done by Cahoon, so we could directly compare to their rates. Our next question of this data was to think about, well, what are people in the ARRAISE cohort who have RHD? What is their cause of death? So for that 2013 to 2017 period, we defined a prevalent rheumatic heart disease cohort and did a qualitative analysis of their cause of death. And here's the results on the right here. We found that for people with RHD who died in that period, around 15% had RHD as their underlying cause of death, and actually 43% had a non-cardiovascular cause, really highlighting the multimorbidity that this group is experiencing. So RHD is needing to be managed in amongst, a very complex mix of other chronic conditions. For Aboriginal and Torres Strait Islander people within this mortality analysis, we actually saw missing cause of death for 15% as well. This pie chart here is for the overall cohort, but within the subgroup of Aboriginal people, this high proportion of missingness. So we were quite concerned at this point that our population level estimates were underestimated, which led to an excess mortality analysis where we used that same prevalent cohort from the qualitative analysis and compared our rates to the background age and population group matched mortality rates. And that was by subtracting our observed in the cohort versus background mortality rates, we were able to get this excess mortality rate value. On the left panel here, you can see the Indigenous population, and on the right-hand side is the non-Indigenous population. And from these rates, we were able to calculate an expected number of deaths for each of the age categories and compare them back to our ABS statistics. And what this showed us was that for non-Indigenous people, we got roughly what we were expecting, but for Indigenous population, we got about half of what we're expecting, really highlighting that this missingness and also indirect causes of RHD mortality are having a big impact within the group. And the final study that I'm going to go over right now is the patterns and costs of acute rheumatic fever and RHD hospitalizations, which was a cost of illness analysis we undertook using the ARRAYS data collection. This was again that prevalent cohort study design, but this time we included acute rheumatic fever and RHD diagnoses. And we focused in on the ARDRG codes, which is the Australian Refined Diagnosis Related Groups for anyone unfamiliar. For this particular analysis, in addition to costs of ARF and RHD itself, we also included those RHD MACE outcomes in the analysis during the study period. For this, we use NWAU calculators, which is National Weighted Activity Unit, applied to the National Efficient Price, and that allowed us to factor in remote and Aboriginal loading factors, which really inflate costs of treating these illnesses in a hospital setting. And these calculators are provided by the Independent Health and Aged Care Pricing Authority. Our analysis was divided into two halves. On the left, we've got our paediatric. On the right is the adult. You can see there were $18 million of costs incurred in the paediatric patient group. These were mostly emergency initiated admissions due to the treatment of acute rheumatic fever. And we saw a trend towards increasing admissions and costs over the 5 financial years that we looked at. In the adult cohort, we had $113 million of costs incurred, and the surgeries in that population were really driving the costs, but these were a stable number of admissions and costs annually. We had the total for this study estimated $130 million over a 5-year period. If we inflation adjust, that's over $150 million in today's money. And this study really highlighted for us and also for advocacy purposes the costs that could be potentially avoided if we can effectively treat these preventable diseases. So that's the end of my few studies highlighting how ARRAYS was used in several different ways to answer clinical and public health questions. I'll now hand you back to Judy, who will carry on.
Thanks, Ingrid. So just a little bit about our outputs. We've been, as you can see from these slides as well, it's been very productive from a publication point of view. We've had over 30 and counting now publications. We've had lots of research students, 3 PhDs, 3 masters and an honours student. Importantly, one of the PhD students led the Queensland NRHD study, which was kind of separate but part of ARRAYS. Dr. Carl Frankier is a colleague now. He's the Torres Strait Islander epidemiologist now working in the space, just recently qualified, so we're very excited. And we've also done a lot of lectures and to medical students and other students where our RHD work has sort of come as part of training and professional training for people, also workshops and so on. We've also been involved indirectly with the Champions for Change, which is a consumer group of people with RHD, people affected by RHD and acute rheumatic fever, and we've had some data literacy workshops working with our data to kind of spread the word about RHD and ARF and empower people to talk about it in a numbers way. A lot of our results are now incorporated into the, this is the END-RHD, the endgame strategy. So as I mentioned right at the beginning, we set up this project initially to feed into the strategy, which it did, but in fact the strategy came out about the same time as our burden study, and ARRAYS has gone beyond really what the endgame strategy has report has said, but the rationale and the aims of the strategy are to reduce and to end RHD in Australia by 2031, and that is a continuing effort, and we participate in all those activities ongoing. A lot of our work is also, as I mentioned earlier, is now in the latest ARF and RHD Australian guideline, and so very much incorporated into the epidemiology chapter of that as well. And that will happen as we go on. We will contribute to the guidelines ongoing. So just coming back to our pyramid now, you've seen this pyramid, you understand the cascade, but there's a lot of research now going on at each of those levels. Since the endgame strategy, there's been a lot of focus on the early treatment of infections, so that's very important. There's obviously a fair amount going on in the more clinical area, different ways of administering penicillin and so on. I won't go into all of those. And of course, a big focus, but not so much work and research going on into the need for intersectoral investments in housing. That's really at the core of it all. Going forward, there's a lot of activity. We are now about to go into Erase 2, where we want to have updated information that we've shown you here, and increase the understanding, because we think that linked data can really add a lot of value, as you've seen in some of our previous publications. So if anybody's interested in Erase 2, we're just getting going now. Ingrid will be leading it, and I think that's very promising. I think also at the same time, we know in Western Australia, we now have the Spotlight funding program from the Fiery Fund, which is our future fund here in WA, and it provides funding of 5 years for a particular disease at a time. And the first one is going to be RHD, and at the moment it's being reviewed who's going to be leading and so on. But either way, Ingrid and I will be involved with that initiative, and we'll see where that takes us. So I think that's really it. We just want to end by acknowledging the numerous people. I'm sure there's people we've missed off here that have worked with us on these on the analyses that we've been involved in. There's been cardiologists, infectious diseases people, surgeons, obstetricians, you name it, they're all there. And just want to acknowledge their wonderful contribution. It's very much a collaborative effort. So thank you very much, and that's it from us.
Thank you, Judy and Ingrid. That was brilliant. Great to see so much work happening over quite a